Bismillah ar-Rahman ar-Rahim wa salatu wassalamu ala ashraf al-mursalin. First, thanks.
الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيد الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. اللهم لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا ما علمتنا وزدنا علما. It gives me a great pleasure to welcome all of you to this event. My name is Dr. Tariq Nasir, consultant endocrinology from King Abdulaziz Medical City, National Guard, Jeddah. I will share this session with my colleague, Prof. Abbas Mansour from Iraq. And before I introduce the speakers, I would like to say a few words about the event. This is the first session of the thyroid webinar, which consists of 6 sessions. It will be every 2 weeks. This arranged by the Saudi Thyroid Group in collaboration with the Arab Thyroid Association. It will be every 2 weeks, inshallah. Tonight we'll have 3 speakers and 3 eminent speakers. And I would like to urge all of you to write the question in the chat, and we will have a special session for question at the end of the 3 presentation. I would take this opportunity to thank the organizing committee, especially Dr. Nasir Al-Jihani, the chair of the Arab Thyroid Association, for this excellent events, and extend my thanks to the sponsoring company, Merck Company. Tonight we'll have 3 speakers. I will introduce the first speaker, Dr. Saoud Al-Sifri. Dr. Saoud Al-Sifri is consultant endocrinologist and diabetes, Al-Hada Armed Force Hospital in Taif. He is assistant professor of medicine in Taif University and director of postgraduate residency training program and director of diabetes and endocrine specialist center in Taif. And his presentation titled Update in the Management of Hypothyroidism. Please, Prof. Saoud, the mic with you.
Assalamu alaikum wa rahmatullah. Thank you very much, Mr. Chairman and Co-Chairman. Thank you very much, Dr. Tariq and Dr. Abbas. And again, thank you very much for the scientific committee, whom they have allowed me to be here with you in such a wonderful event, which is Thyroid Academy. I'm very, very much honored to talk about one of the topic that always we face. So here we are talking about our patients whom they have got hypothyroidism, and in this hypothyroidism we wanted to see what happens with those their managements, and then at the end I'm going to share with you a few slides on 3 kind of population that we might see more commonly in the clinic. So I wish that this will be an update, and as well as it would be revision for what we know about the hypothyroidism. These are my disclosures, so I have nothing to disclose for this presentation. Now, when we talk about hypothyroidism prevalence, it usually corresponds to the age as well as the gender. So as you could see and appreciate from here, that when you talk about those young populations, always it is low. So it is considered to be around 5 to 10% up to age of 50. Now, once we talk about elderly, whom they are more than 50 years of age, then this prevalence might reach up to 22%. Now, remind you that the difference in gender is always there. So they used to say that hypothyroidism or thyroid disease is more of a female nature. And that's also true when you look at statistic. So here you would see that in the pink, that always female at any given age, they are more than the male. So it's more predominant of female age. Now, once we look into our country, then you would find that there is a different local reports, which comes from different centers. So it depends on which population you are studying, and according to that, you are going to face. So in average, it has been reported in different local studies that it is around 10%. Now, the worrying thing is really that more than half of them, they were undiagnosed. So in these cross-sectional studies, when they looked, the average prevalence was around 10%, but the most worrying thing that almost half of them, they don't know that they have got hypothyroidism. And this might enlighten us in the coming future what to look. Now, most of questions are always related to what are the causes of hypothyroidism. So now I wanted just to say that it is usually an autoimmune and Hashimoto thyroiditis in more than 95% of the cases. So it is an autoimmune nature. It is Hashimoto thyroiditis that always what we face in those hypothyroid cases. Now, other cases, it could be iatrogenic, either to those who had post-surgical hypothyroidism or whom they had irradiations, either as external radiation or radioactive iodine due to thyroid cancer. So those, again, they are almost 3 to 4%. Now, post-thyroiditis, this is either subacute or postpartum. This is, again, an autoimmune thyroiditis, but it has got a variable nature that it might start with hyper and then it go into hypo, and then they might end up with hypothyroidism. Now, there are medications in which we have to think in patients who comes with hypothyroidism, whether they had been using. One of the most, I would say, famous one is amidrone. Remember that amidrone, it should not make a confusion for you. It can cause both cases, either hypothyroidism or hyperthyroidism. It depends on the iodine status of that patient. So in those who are having, let's say, iodine-rich thyroid, they might cause hyperthyroidism, while in those who have got iodine or hypo store of their iodine, it might cause hypothyroidism. Again, rifampicin is one of those famous medications. Now the question comes, so what? If I'm having a hypothyroidism, does it have any consequences in our body? And I think you could appreciate from here that, yes, it has a lot of consequences. And among them, if you would see, we're talking about different organs. Now, one of them is the cardiovascular, and in that, the most prominent one is the heart rate. So in those, they would have bradycardia. And the other important thing is really the increased diastolic blood pressure. So whenever the heart at diastolic stage, the ventricle, it has got an increased intraventricular pressure. The other thing is really the contractility of the ventricles is always reduced with this hypothyroidism. Now in CNS, it has got a variable. So it ranges really from decreased mental concentration. So you would find people who are apathic, or they could have impaired memory, or they might reach depression, or even coma or semi-coma. So it depends at which stage of hypothyroidism is there. Remember that hypothyroidism is always a state of hypofunction. So you would expect hypofunction in all organs, and this is not to exclude the gastrointestinal system, in which there would be constipation or decreased GI motility. In muscles, and this is always we feel that patient, they would have weakness, myalgia, cramps, or pain, and sometimes even muscle stiffness. Now, in examination, you might find slow muscle stretch reflexes, so deep tendon reflexes might be relaxed or decreased in those. Again, having hypothyroid will reduce the estimated GFR in those, and they would impair the free water excretion from this. that might lead to hyponatremia with more fluid retention and edema in those severe cases of hypothyroidism. Now, reproductive system is also affected with variable degree of hypothyroidism. So it could, in those who are growing at pre-pubertal age, they might have arrest in their growth and they would end up with short stature. Others, they might have, in ladies, menorrhea or amenorrhea or anovulatory cycles. Some of them, they might have infertility or subfertility, either at male or female. Now, again, the liver is affected, and in that you would expect maybe high triglycerides, and sometimes they would have decreased hepatic LDL receptors, and that would lead to reduction in the cholesterol clearance, and that would lead to high LDL in those patients. Again, remember those drugs which is catabolized by liver, it might be affected by hypothyroidism. Now, again, another important system is really the skin and hair. And this is sometimes we faced it as one of the most common adverse events that they look towards hypothyroidism. So hair fall and having a dry skin are one of the most common symptoms or signs that we see. So dry skin, thick skin, coarse skin, and sometimes hair fall or losing the lateral side of the eyebrow could be signs of affection of the hair in those populations. Now, another thing to remember that in those patients, diagnosis is always limited. And the reason for that, because of these signs and symptoms of hypothyroidism are common among more than 20, 30 diseases. So if somebody comes, for example, with dry skin, it could be related to different reasons. So in this study, they wanted to correlate the symptoms along with the lab work. So in those who has got more elevated TSH, which indicates primary hypothyroidism, in this you would see that mostly it is related to poor memory, thick skin, and slow, let's say, mental processing. All of these are related or more correlated to hypothyroidism or hyperthyroidism. So these, remember, these are not specific, and the accuracy of these symptoms are limited. That's why when we come to diagnosis, always we wanted to look into other things. So now remember that when you talk about hypothyroidism, we're talking about hypothalamic pituitary thyroid axis. And this axis is affected by the thyroglobulin releasing hormone and the thyroglobulin stimulating hormone. So this is from the hypothalamus. It would stimulate pituitary to release the TSH, and that would end up by releasing the thyroid hormone. Now, this has a negative feedback. So once the thyroxine level is enough at the circulation, that would have a negative feedback at the pituitary and in the same time hypothalamus. And that would lead into normalization of the TSH and TRH. Now, it depends where is the defect. So here, if you talk about thyroid, it means here there would be more of TRH and more of TSH. And the thyroid is not responding to TSH. That's why you would have more of this TSH in the circulation. Now, it's important to remember the natural course of the hypothyroidism. So here, if we talk about this is the normal range for those with TSH or free T4, it depends at which level you're catching your patient. This patient is still under euthyroid, so still has got a normal TSH and normal T4. But look here, once they would start having mild, moderate, or overt hypothyroidism, they would have initially an increase in their TSH before even having a defect in the T4 level. That's why initially they might start with subacute hypothyroidism. If you happen to catch your patient lately at those stage of overt hypothyroidism, then you would have then you would find the TSH is very high while the T4 is low. And this is late, I would say late hypothyroidism. Now, we wanted to know, now we have got a normal range for TSH and T4, and we want to correlate this with the age. Now, does all age has got the same? Now, just remember, now, if we talk about age of those young populations, usually it has got an age which is between 30 and 60. So in those, usually we would have almost 30% of them, they would have more shift towards the right. While here, if you talk about individuals or elderly people who are more than 80 years of age, they might have even a slow TSH, which is normal. So the TSH level, it depends really on the age. So 95% of confidence interval is always between 0.5 to 5 milligram per deciliter. Now, what to do with those? Now, we knew that we have got around 10% in populations. The problem, 50% of them are undiagnosed. Now, should we screen all populations or should we look for case finding studies? Now, screening, you can do it for everybody, but the problem that it's very costly. So just imagine if you will do it for 1 million people to screen for them, it's always very costly. Now, the good thing about case finding that you would do testing or screening for patient who has got risk factors or who has got prediction for having hypothyroidism. So here, this would give you even more positive results. Now, case findings, always we depend on children. We always suggest that you should screen those who has got either short stature or delayed growth or who has got delayed or premature puberty. Others who has got certain behavior changes like attention deficit of hyperactivity syndrome. Those, they worth to screen them at any stage. Now, what are the other risk group? The other who has got other autoimmune endocrine disorder, like somebody who has got adrenal insufficiency or hypoparathyroidism or premature ovarian failure, those are worth to screen them with TSH. Now, other who has got other autoimmune diseases which is not related to endocrine, like those with Sjogren's syndrome, scleroderma, vitiligo, or celiac disease. Again, it is an autoimmune disease, not related to endocrine, but you could have a positive test in those. Now, remember, for those who has got a family history of autoimmune thyroid disease, they are worth to screen them for this. Now, if they have got those symptoms, then we wanted to know whether these symptoms or signs that they have got, is it a new or it has been sustained for more than 2 weeks and it is unexplained. So if somebody comes to me with chronic, let's say, constipation, and I did all investigations, I did not find an organic cause, then this could be a justifiable reason for doing TSH. Now, those high risk group, we wanted always to examine them and screen them, especially those pregnant ladies, postpartum ladies, or elderly who has got signs and symptoms of hypothyroidism. Like, for example, gaining more weight, getting dry skin, having difficulty, and losing more hair. Those categories, I would examine them for TSH. Now, hypothyroidism could be associated with all of these lab work, but remember that anemia sometimes, normochromic normocytic anemia, or high triglyceride and LDL, or having hyponatremia, or having high prolactin could explain, and especially if patient is having CK, and even if it is MB specific, it could be related to hypothyroidism. Now, the subclinical, I think Prof. Abdurrahman Sheikh is going to talk in that in detail, but this is usually when you catch your patients early. So here we want to say it's one course of the disease, but it depends where did you test your patient. Is it at this stage where TSH is high while T4 is normal, or is it at this stage where both of them, this is high and the T4 is low? Now, we wanted to see for those patients with subclinical, what to do with them. And again, Dr. Abdurrahman Sheikh is going to talk about this in details, but this is just to give you an overview on the consensus that we had. In patients who has got a very high TSH, in that case, we would treat him as a offered hypothyroidism. For those who have got TSH, which is below 10, and their T4 is still normal, usually the message I would say, reassess in the beginning, and then after 2 months, repeat that test, except if patient is having compelling indications, which is lady who has got infertility or subfertility, amenorrhea or menorrhagia, or a man who has got subfertility or other unexplained symptoms, you might do it with that. So again, this is what we've been talking about in those subclinical. Please, especially in pregnant lady, you have to treat them, and always remember that in this hypothyroidism primary one, the TSH level target always has to be. How to select and to get the appropriate dose is important, and then what other things that it might interfere with the medications and those potential adverse events that we might see. Now here for the treatment of hypothyroidism, here it is always levothyroxine. So this is more than enough, and always the good thing that it resembles the normal thyroid physiology, with more than almost 80% of that T4 is coming from the conversion of T4 into T3 in the peripheral tissue. Remember that when we were comparing both, now some people, they might say, should I use the combination of T4, thyroxine, and cytomel, which is T3? In all studies, they find no benefits of combining T3 with T4 in replacement therapy. Now, 90% of this thyroxine, it's absorbed, and the good thing that it happens in the proximal region. The good thing that the half-life is almost 7 days. So this gives it once daily effect. That's why we are using it on a single daily dose. Now, you could adjust the time according to your patients, but remember few things that you can give it to your patients on empty stomach. And the reason behind this, that some of these other medications, it might interfere with the absorption of thyroxine. So the only thing, you would need patient at least to have 1 hour fasting, so they can take it either the first thing in the morning, or maybe the last thing before sleeping, or at any time of the day once they have got like 1 hour fasting. Remember that if they miss the dose of today, for example, your patient is taking 100 microgram per day, if they missed it for a reason or other, tomorrow they can compensate, or they can combine both doses, the one which was missed with the other one. Now, this is just for your information, that we don't use it in routine practice, but some people whom we find very difficult compliance or adherence, they might take it once weekly. So the total dose, for example, is 700 microgram. They might take it once a day, once per week. But this is not a routine clinical practice, except in some few patients where we find difficulty with adherence or compliance. Now, how much should we target the TSH? Now, I've started treatment for my patient with hypothyroidism. So how should I do? Now, remember, it's always, the clinical status is not usually very accurate. And the reason behind that, there is a lag between the clinical improvement and the laboratory improvement. So always TSH should be the principal guide in patients with primary hypothyroidism, where the problem in the thyroid. Now, always remember that there is a lag between 1 to 2 weeks between the let's say the concentration in the serum and the free T4 level in the circulation. Remember that now we are using a very highly sensitive assays so that it can detect even minor changes. Um, we don't use TSH in cases of central, which is secondary hypothyroidism, because TSH is always low. So in that case, we go with T4, yes. The target range, it depends really on which populations you are treating. So here, if we are treating the primary, in that the TSH and they are low, they are young, 0.5 to 3, that would be very good for them. If we are treating primary for those elderly, we might be happy with 1 to 4 as a level. For secondary hypothyroidism, remember that we don't use TSH, we use T4. So in that situation, I would use the upper third of normal range in your lab. So for example, in our lab, it ranges between 9 and 19. So for me, I will be happy that my patient is 15 and above. Now, other thyroid cancer, really, in that situations, we are talking about different situations where we need to suppress TSH. So by that, I would give higher doses. But here we're talking about more simple cases of hypothyroidism. Now, how much should I start with thyroxine? This is in general that we give 1.6 microgram per kg per day uh, per day for adult non-pregnant lady. So in that, for somebody who's like 75 kg, I would be happy to start with 100 microgram per day. So remember that in children, the dose is higher. Why? Because their weight is small and they have got more renal clearance of thyroxine. So just remember that in neonate up to 6 months, we might use 10 to 15 microgram per kg per day, while in adult, it is only 1.6. Remember those, as they grow up, we reduce the dose. So for those children whom they are more than 2 years and they are less than 18 years, we might use 5 to 6 microgram per kg. And those elderly, they have got the opposite, which is decreased clearance, renal clearance of thyroxine. So we might use, instead of 1.6, we would use 1 microgram per kg per day. Now, remember that again, those who are pregnant, they would have more renal clearance. So in that, we might use an average of 3 microgram per kg per day. Remember that adjustment for pregnancy, it has happened every trimester of pregnancy, and that's always an important to remember. Now, this is just to show you that once we replace thyroxine, how many of them they would have more of hyperthyroidism. So we make them iatrogenic thyrotoxicosis, or still they would not have hypothyroidism. So in average, it is between 10 to 20% that we might induce thyrotoxicosis, or we might induce or continue with hypothyroidism. Now remember, these common medications are always interfering with the absorption of thyroxine. So if your patient taking 100 and he was fine, and then suddenly his TSH goes up and he's very compliant, maybe he's taking some iron or calcium supplement or bile acid sequestrant, or those sacral-phate or protein pump inhibitors, or those antacids like H2 blockers. These are common, and it might cause a reduction in the absorption of this. This might reach up to 30% of the total dose that they are taking. These are other medications which might cause it. So remember that it could be there. Now, remember.
Dr. Saud,
Yep.
Time is up.
Okay. In last 2 minutes, please.
Yeah.
I'm just finishing. In those, I would just go into one case, and this case is really a common case that we always see. 56 years old woman who's complaining of weight gain over the last 15 years, and she has got myalgia and constipation for 3 months. She's fatigued, and this is her pulse 68. Thyroid is normal, and she have got normal deep tendon reflexes. Now the question: do you think she worth doing for her TSH for possible hypothyroidism? I think the answer is yes, because she have got complaints which is not explained. And with this, we did serum TSH, which was very high, 38, and her free T4 was 6. So this is really a real case for thyroxine replacement. Now, what is the most common cause? Yes, Hashimoto thyroiditis. And then we don't need really to measure the thyroid autoantibodies because it is a straightforward case. Now, with this, I finished, and these are my final conclusions slide. Hypothyroidism is really the usual result of autoimmune thyroiditis, Hashimoto's diagnosis. We cannot depend on the clinical impression, but usually with serum TSH and free T4. Levothyroxine is the treatment for choice, and always we have to assess with TSH alone rather than with TSH and free T4. Thank you very much for your listening, and thank you very much.
Thank you, Dr. Saud. Dr. Abbas, please, the mic with you.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين.
Mr. Chairman. Next speaker, Dr. Ali Khalil. He is consultant endocrinologist, Imperial College Diabetes Center, Abu Dhabi. Graduated from University of Marseille, France, Internal Medicine, Queen University, Canada, Endocrine University of Toronto, Canada, and he is FACE, Fellow of American Association of Clinical Endocrinology. Dr. Ali Khalil, he will be talking about management of hyperthyroidism case-based discussions. Ustad Ali Khalil, now it is for yours. The mic is for you. Thank you.
Just 1 second.
Okay. But I need to announce that we have to have a questions. The question should be sent as a question through the chat box. It will be translated to us as a chairman committee. The question will be, the answer to the question will be at the end of this presentations at around 9:30. We have another one speaker after Dr. Ali Khalil.
Yep.
We need to see the questions from now. Okay.
Thank you very much, Mr. Chairman. Thank you very much for the attendees at such a late hour of the night. I'd like to thank the organizer for inviting me to be part of those eminent speakers. And the topic I've been assigned to give to you tonight is hyperthyroidism case-based discussion. Now, I have to say to start with, I have no conflict of interest to disclose, but to introduce the topic, since it's case-based, I have to go through just a small introduction. First of all, let me attract your attention to the fact that for years, I used to think that hyperthyroidism and thyrotoxicosis are synonymous.
السلايدات انت ما شغلت السلايدات.
Okay.
Thank you.
Thank you very much. I really apologize for you guys.
Okay.
I don't know whether you heard my introduction. Basically, I'm a consultant thyroidologist at ICLDC. And the topic I have to give you tonight is hypothyroidism. And the message given to me, it has to be case-based discussion. So, but again, I cannot do it not knowing the degree of knowledge of the attendees. So for this, I decided to give you a little bit of introduction on the topic. So to start with, let me pinpoint important aspect of the topic. For years, I used to think that hyperthyroidism and thyrotoxicosis were synonymous. In fact, they are not. And I would like you to make attention to this. Hyperthyroidism is characterized by increased thyroid synthesis and secretion from the thyroid gland. Thyrotoxicosis refers to the clinical syndrome of excess circulating thyroid hormones, irrespective of the source. So that's how, when we talk about causes, you have those thyrotoxicosis cases with hyperthyroidism, where there is increased synthesis and secretion of thyroid hormone. And the causes could be either to increase thyroid stimulation by antibodies, like in the case of Graves' disease, by TSH receptor antibodies, or inappropriate TSH secretion, as in the case of TSH secreting pituitary adenoma, or pituitary resistance to thyroid hormone, or excess SCG secretion, as we see in some pregnancies that patients complain of hyperemesis gravidarum, or pathologically the secretion from tophoblastic tumor, choriocarcinoma, or hydatiform moles. Now, other cases where you have autonomous thyroid nodule, you have activating mutation in the TSH receptor, or more specifically of the GS alpha moiety of the G protein. This is caused by solitary hyperfunctioning adenoma, or multinodular goiter, or familial non-autoimmune hyperthyroidism. Now, in thyrotoxicosis without hyperthyroidism, here there is either an inflammation and release of stored hormones, such what we see in cases of autoimmune destruction of the thyroid gland, commonly seen a few months after delivery, like we call it postpartum thyroiditis, or due to viral infection. A few weeks after viral infection, the patient complains of pain in the anterior part of the neck, and this could be due to subacute thyroiditis, known as Dickervan thyroiditis. Some drugs can induce that effect. Amiodarone, as mentioned by Dr. Saud, that's one of the culprit in causing toxic effect and causing destruction of the thyroid gland. Some drugs like lithium, interferon alpha, used for the treatment of viral hepatitis. Rarely you could see it with bacterial or fungal infection. I had 2 cases I've seen since I've been in Abu Dhabi due to tuberculosis thyroiditis. Thyroiditis caused by tuberculosis. Radiation, if you get exposed, the body gets exposed to external radiation involving the thyroid, we call it radiation thyroiditis. Now, sometimes the thyrotoxicosis without hyperthyroidism could be due to extrathyroidal source of hormone, such as excess intake of thyroid hormone in patients who factitiously take extrathyroid hormone, or in the cases of ectopic production of thyroid hormone by stroma ovari from the ovary, or from functional thyroid cancer metastases. Years back, actually, I was still in North America at the time, close to 25 years back. There were cases of hyperthyroidism caused by ingestion of beef cows that really were fed excess amount of iodine. And the ingestion of that feed of iodine caused really hyperthyroidism. And as was mentioned previously, in cases where you have in areas of low iodine intake, you give them a lot of excess iodine, and this is with time cause what we call the Jod-Basedow effect, and the patient will present with autonomous secretion of thyroid hormone. Having said this, the symptoms of thyrotoxicosis are classically due to the interaction of thyroid hormone with the adrenergic system and increase the metabolic metabolism. So the result symptoms are increased heat production, feeling hot, increased sweats, weight loss, increased appetite, tremors, nervousness, increased bowel motility, palpitation that you feel. This is very common, along with the tremor, those very two common symptoms. Shortness of breath, if really it's advanced stage, and menstrual irregularities. And typically in the autoimmune thyroid disease, Graves' disease, you have eye changes, bulging eyes, eye swelling, and retroorbital pain or discomfort. And the treatment, you have to look at the cause, whether you're dealing with thyrotoxicosis with hyperthyroidism or without hyperthyroidism. In the case of treat with thyrotoxicosis with hyperthyroidism, obviously the treatment that we have consists of either medical therapy, symptomatically using beta-adrenergic blockers, or antithyroid medication that block the organification of the thyroid, the hormones, and then, or the release of thyroid hormones, such carbimazole, which is the precursor of metimazole, or propylthiouracil, and those are used usually if there is intolerance to carbimazole or metimazole, because the first two ones they have longer half-life, so you could use them once or maximally twice daily. In case of autonomous thyroid nodule, obviously hemithyroidectomy is sometimes used, or the use of radioactivity is also another method of treatment. In case of Graves' disease or toxic multinodular goiter, total thyroidectomy or radioactive iodine is the treatment that is usually chosen. I had to go to this before getting to our case. So the case is a 40-year-old patient, previously healthy, known for obesity, hyperlipidemia, and he gave a history of COVID-19 that he suffered from 8 months previously. He recovered reasonably well, but he presented to our clinic 2 weeks after he had received a Pfizer SARS-CoV-2 vaccine. Now, the history he gave that 3 days after he received the vaccine, and take note of the duration, 3 days after receiving the vaccine, he developed symptoms of nausea, vomiting, fatigue, insomnia, palpitation, and muscle weakness. The muscle weakness actually was almost paralysis. He could not move his legs or his arms, upper arms. And he did check in the emergency room of Cleveland Clinic in Abu Dhabi, and at that time he was found to have fine distal tremors, and he had increased stretch reflexes, arrhythmia, heart sounds the heart sounds were irregular, and then he had, as I mentioned, the proximal muscle weakness. So the history he gave, which we were able to retrieve his blood work from Cleveland, because now most hospitals are interconnected. Some of the hospitals connected to get information from each other. His white count was on the low side. His neutrophil count was 1,500. His liver enzymes were elevated. His ALT was 134, AST 56. His normal alkaline phosphatase. His potassium was quite low, was 1.9, despite the fact his EGFR was normal. His thyroid function test was abnormal. His TSH was definitely suppressed as less than 0.05. And in parentheses, you have the normal range values. FT4 was quite elevated, 42. FT3 was up, 13. The antithyroid antibodies were high. Antithyroid globulin antibodies were high, and as well as the anti-TSH receptor antibody. So the patient had a feature of autoimmune process. He was admitted to the intensive care there at the hospital. He was hydrated. He was given replacement potassium, and he was discharged home on medication to address his bout paroxysm of atrial fibrillation. He was sent on propranolol, diazepam. By the way, he required actually cardioversion when he was in the emergency room. And he was given metimazole, 10 milligram daily for his hyperthyroidism, potassium supplement with good instruction to avoid high carbohydrate load. When I saw him in the clinic, he was asymptomatic, but he was quite concerned about this case because he was afraid of that paralysis he had. His TSH was still suppressed. As you know, Dr. Saud mentioned, there is a lag between the free T4 and the TSH by 2 weeks, 2 to 3 weeks. His free T4 was getting very close to normal, was still elevated at 28. His free T3 was also very close to normal, and the TSH receptor antibodies were still elevated. His serum potassium was corrected, and his CRP was back to normal when it was elevated in the emergency room. In giving his history, he has one brother had history of Graves' disease, and his mother is being followed currently by nephrology for recurrent hypokalemia. An ultrasound done in my office still showed really the thyroid is enlarged and quite vascular, as you can see from the Christmas tree, the color that you see over the thyroid gland. Now, the question here is, I have a few questions that really will take you through. If we have the time, we'll stop really if time need to. Does our patient fit the criteria for what we call autoimmune induced vaccine syndrome, post-COVID vaccine induced autoimmune disease? And to answer this question, let me take you over what's really known in the literature. Pfizer vaccine, actually looking at what Pfizer, the adjuvant for Pfizer vaccine, contains 4 lipids, of which 2 have not been widely used in previously authorized medicinal products. 3 of them are based on polyethylene glycol lipid conjugates, the stabilized lipid, the nanoparticles that covers the messenger RNA that was put in the RNA particle put in that lipid particle. And that the main function of it is to reduce the activity of non-specific binding protein. And the PEGs usually are relatively safe, but may act as an adjuvant, and they have been known to induce an immune response in predisposed individuals. Now, Asia is what has been described as autoimmune or inflammatory syndrome induced by adjuvant. And this is really the syndrome described, associated usually with post-vaccine use, and has been associated with some endocrine diseases, with the appearance of clinical manifestation usually described appearing between 2 to 60 days after vaccination. So what are the criteria really to get really to be called? And actually, if you remember, 4 major syndromes have been attributed to the what we call the ASIA, is the macrophage syndrome, the silicone-related disease from women having artificial breast filled up with silicone, and the Gulf War syndrome that really have been people getting sick after getting to the Gulf area and giving anthrax vaccine and other post-vaccination event. So you have to have few symptoms. And if you look at the screen, I don't know if you can see my arrow here. You can see myopathy, weakness, arthralgia.
Yes,
Thank you. Chronic fatigue syndrome, some fever, GI symptoms, the presence of autoimmune markers such as thyroid antibodies, increase CRP. Okay, so the constellation of few of those symptoms will put the patient in that category of Asia. And if we look at our we go back to our patient, he had all the symptoms. He has the muscle weakness, he has the neurological symptoms, he had the GI symptoms, he has the antibodies, he had the elevated CRP. So he definitely fit in this category. So this is the first thing that really I want to discuss here. So the second point is now that we have evidence, definitely he has all the criteria of autoimmune thyroid disease. He has enlarged thyroid, active thyroid, by Doppler is really quite active. He has elevated thyroid indices. The TSI, which is the TSH receptor antibody, is high. So it has the criteria of what we call really Graves' disease. Now, in those cases, how safe is it to treat a patient with anti-thyroid medication, which are known to induce cases of leukopenia and drop in the white count, if the patient already presented with low blood count? As you remember, in this case, the absolute neutrophil count was 1500, and he had elevated abnormal liver test. And anti-thyroid medication are also known to induce thyroid indices. So my question to you here, based on the recommendation of the ATA 2016, the statement, is it true that ATA mentioned to avoid anti-thyroid drugs if the absolute neutrophil count is less than 1500 per square meter due to lack of available data and the increased risk of fatality? The answer is true or false. I'll give you just maybe 1 second or 2 seconds to answer this question and to make you think about it. And you will answer. Okay, the second question is it true that propylthiouracil at any dose appear to be more likely to cause agranulocytosis when we talk about agranulocytosis less than 1000 compared to low doses of metimazole? True or false? You can answer actually in the answer, chat. Now, I did review the literature for you, and it's interesting to know that anti-thyroid drug side effect, they can cause minor allergic reactions, such pruritus or minor rash in 6% of patients taking metimazole, and 3% of patients taking PTU. Now, there are some hepatocellular injury that occurred, but in minimal cases, 2.7% of patients taking PTU and 0.4% of patients taking metimazole. But serious autoimmune induced hematological complication, the incidence, although it's low, but it's there to cause agranulocytosis, 0.1 to 0.15%. Now, although agranulocytosis induced by anti-thyroid medication is uncommon, but it's life-threatening. So there are patients, they can die from this. And interestingly, PTU at any dose, from reviewing the literature, appears to be more likely to cause agranulocytosis compared to low doses of metimazole. So this interesting meta-analysis, they looked at 1,880 studies, of which 13 studies, 1,144 patients, were included in the systemic review and meta-analysis. And all they had, 103 had neutropenia. And they look at the prevalence of neutropenia in newly diagnosed as untreated patients with Graves' disease, overall estimated to be 10%, with a confidence interval of 5 to 19%. And the summary is that the mean ANC, which is absolute neutrophil count value in neutrophilic, was 1400, similar to our case, okay? But more severe neutropenia, less than 1000, was very rare. And as mentioned before, 0.1 to 0.5% of the cases. In all 84 neutropenic patients under anti-thyroid therapy who had repeat white blood cell count, neutropenia after treatment with anti-thyroid medication resolved within 14 to 55 days without worsening of the baseline ANC values for the development of agranulocytosis. So the conclusion, both based on this meta-analysis and the AT guideline of 2016, mild to moderate neutropenia is common in hyperthyroidism due to Graves' disease and is not a contraindication to the use of antithyroid medication. And it concurs with the American Thyroid Association, the ATA guideline 2016, to avoid antithyroid medication if the absolute neutrophil count is less than 1,000, not 1,500, 1,500, due to lack of available data and the increased risk of fatality. The other thing is it true that to avoid the use of antithyroid drugs, if the baseline elevated liver function tests are twice above the normal upper limit of normal? Answer yes, true or false. Okay, because of the sake of time, I have to move on. Liver enzymes, as in this case, are commonly elevated in untreated hyperthyroidism. And a systemic review reviewing this for you and meta-analysis assessing the prevalence of serum liver function in patients with newly diagnosed untreated hyperthyroidism, whether they have Graves, toxic adenoma, or toxic multinodular goiter. They have 25 cohort studies, 5 prospective, 20 retrospective. They looked at liver function tests, and the primary outcome was prevalence of at least one abnormal liver function test. The second outcome assessed was prevalence of resolution of abnormal liver function tests after restoration of euthyroidism following treatment with antithyroid medication. And overall, the prevalence was in the range of abnormal liver function tests, at least one abnormal function test, was between 55 and 60%, and variable between one type of liver enzyme to the other. But again, if you look at the heterogeneity of those studies, really quite high heterogeneity because of the way the studies were done. But overall, it seemed that's really quite prevalent to have abnormal thyroid indices in patients newly diagnosed with hyperthyroidism. So serum liver abnormalities are common among patients with newly diagnosed and treated hyperthyroidism. However, a large proportion of these patients had normalization of abnormal liver function tests after restoration of euthyroidism following antithyroid treatment with antithyroid medication, and initiating an antithyroid medication if the baseline elevated liver function tests are within 5 times the upper limit appear to be safe and reasonable. But again, you have to keep caution if really you have very high abnormal liver function tests. Having said this, I don't know if I still have time or not, Mr. Chairman, is this episode of hypokalemia likely to recur in this patient? Now you have to know why this patient had hypokalemia. He had hypokalemia because he had what we call acquired form of hypokalemic periodic paralysis. This is a type that acquired with thyrotoxic patient in those who have some predisposition similar, that gives a picture similar to what's known as familial autosomal dominant that usually occur in the first decade of life, whereas the acquired form usually occurs after the age of 20. Now, in this type, they have attacks of generalized weakness, usually proximal muscle weakness, usually precipitated by rest after strenuous exercise, high carbohydrate load that resolve with treatment of hyperthyroidism. And then Graves' disease seems the underlying disease in most cases, with incidence mainly in Asian, 2% versus 0.1, 0.2% in non-Asian. And contrary to what really have been known that thyroid disease occur in female, this condition males seems to be more affected than females. Pathogenesis is not well understood, but they feel that really there is problem with the channel responsible for the sodium ATPase, potassium ATPase pump that is make them predisposed to those kind of symptoms. This is present at the level of skeletal muscle and is usually triggered by excess thyroid hormone, and secondary is increased responsive to beta-adrenergic stimulation. So beta-adrenergic stimulation leads to increased movement of potassium from the extracellular compartment to the intracellular compartment, leading to hypokalemia. Hyperinsulinemia is also one factor. And this patient has feature of hyperinsulinemia. He was obese, his fasting was impaired, and high insulin, you know, that is well known to shift potassium inside the cells. And there has been some speculation that also high testosterone might act at the same level, the same channel to cause the same type of movement of potassium. Occasionally, some studies, they looked at a portion of patients they found that they have higher expression of a mutant of a gene called ACNG2 gene that encodes for KARE 2.6, which is known to as rectifying potassium ATPase channel. And they seem that when they are defective, this syndrome seems to be precipitated if hypothyroidism is present. So in conclusion, I'm getting to the end of my talk. Asia is associated with autoimmune endocrine diseases, and the most common one are Graves, subacute thyroiditis, when we have seen few cases, and Dr. Tariq at the GATE meeting also had few cases. I had so far like 8 cases of subacute thyroiditis and 2 cases of Graves' disease post COVID-19 vaccine. Mild to moderate neutropenia is common in hyperthyroidism due to Graves' disease and is not a contraindication to the use of antithyroid medication. To avoid the use of antithyroid medication if the absolute neutrophil count is less than 1,000 because of increased fatality, and initiating an antithyroid medication, antithyroid drug, if the baseline elevated liver function are within 5 times the upper limit appears to be reasonable. And with this, I'll end to the conclusion of my talk. Thank you very much.
Thank you, Prof. Khalil, for this excellent presentation. Our third speaker tonight will be Prof. Abdurrahman al-Sheikh. Professor Abdurrahman al-Sheikh is a consultant in endocrinology and diabetes in Dr. Salman Faqih Hospital, Jeddah. He is the chairman of the Saudi Society of Diabetes since 2009, and he was the chairman of medicine department at King Abdulaziz University Hospital, Jeddah. His presentation titled Subclinical Thyroid Disorder When to Treat. Prof. Abdurrahman, the mic with you.
Bismillah ar-Rahman ar-Rahim, wa salatu wassalamu ala ashraf al-mursalin. First, thanks, Mr. Chairman, and thanks for organizing committee for inviting me to be with you tonight. And I'm going to talk about the subclinical thyroid disease guideline and scientific review and management. My objective for this lecture will be the definition, the causes of subclinical thyroid disease, when we should screen for subclinical thyroid disease, sign and symptoms of subclinical thyroid disease, differential diagnosis, and at the end we'll talk about the guidelines and the treatment and when we treat. What we mean by subclinical hypothyroidism, the definition. This is usually what with normal T4 and high TSH. When you have a patient with normal T4 and high TSH, we call this result as subclinical hypothyroid. 60% to 80%, you might find anti-TPO. The patient has mild symptoms. You might have all the thyroid symptoms. Sometimes some people, they call it mild hypothyroidism or mild thyroid failure. So patient with normal T4 and high TSH, we call it subclinical hypothyroidism. Causes, it is either due to the autonomic immune thyroiditis or due to the iatrogenic, where the patient receives higher dose of thyroxine. Some drugs like metamazole, lithium, amiodarone, toxin, and infiltrative diseases. So the causes commonly due to the autoimmune thyroid disease. What's the risk factor for subclinical hypothyroidism? It is familial history or family history of thyroid disease, personal history of thyroid diseases, presence of antibody, thyroid antibody, radiation treatment to the head and neck or chest, other autoimmune disease, and medication. This is what we call the risk factor, and also the old age is one of the risk factor for subclinical hypothyroidism. When we should suspect mild thyroid failure or subclinical hyperthyroidism, when you have high cholesterol, refractory depression, previous episode of postpartum thyroiditis, patient with goiters, patient with symptoms suggestive of thyroid disease, family or personal history of thyroid disease, age above 40 with non-specific complaints, insidious weight changes, unexplained infertility, or increased weight. This is where we suspect mild thyroid failure, and we have to check the thyroid function. What about the epidemiology of subclinical hypothyroidism? All over the world, it's a prevalence of subclinical hypothyroidism between 3% to 8% in the population without known thyroid disease. The prevalence increases with the age and is higher in women after the sixth decade of life. The prevalence in men approaches to the 10%. So the prevalence of subclinical hypothyroidism, it's increased with the age and more common in women than men. This is a study which is done in our university, where we looked at the subclinical hypothyroidism epidemiology in our hospital, and we found it is not far away from the worldwide prevalence between 3 to 8. And we found it in our study, it is 7% and more common in female than male, and more in the older age than the younger. And this is just to show you the graph of our study, where they found that more in female than male, and also it's more in the age above 40 years. So it's more in the age of above 40 and more in female. And this is again the epidemiology of subclinical hypothyroidism, where the TSH more than 5, as I mentioned, it is more in female and more above the age of 60 and above the age of 70. So more patients we see with the ages and more in female than male. What's the symptoms of subclinical hypothyroidism? It's not far away from the symptoms of hypothyroidism. It is fatigue, malaise, constipation, weight gain. Some patient might have alopecia, menorrhagia, some muscle pain, unexplained depression, bradycardia, hyperlipidemia, anemia, goiter, which is similar to the hypothyroidism, and might be there is no symptoms or asymptomatic patient. What's the differential diagnosis of patient with subclinical hypothyroidism? Some changes in the TSH, we might find it in some patient with thyroiditis or with hospitalized patient, what we call the cyclothyroid disease, and some patient with the psychiatry illness, we might find that there is some elevation or increase in the TSH level. Or it's a variability. Sometimes some labs might have some wrong results. So we have to think about variability of the SAS and the lab. But sometimes with hospitalized patients, we might find slightly increase in TSH, or in patient with thyroiditis, recovery thyroiditis, you might have a slightly increase in TSH. Other differential diagnosis, patient with the TSH producing pituitary adenoma, or central hypothyroidism, morbid obesity, some changes in TSH, and also presence of heterophilic antibodies, which is falsely in the test might find increase in the TSH. So this is the differential diagnosis where you can find normal T4 with the increase in the TSH. What the consequences of subclinical hypothyroidism? What's happened to the patient when you have a subclinical hypothyroidism? Either some of them back to normal, or progression to overt hypothyroidism. In some patients, they showed that increase the cardiovascular diseases, increase in the lipid profile, and reproductive abnormalities. And some patients might have also non-alcoholic fatty liver disease. So many of the patients might progress to hypothyroidism. So as I said, that in presence of the TBO, 2.6% of the patient each year might they go to the hypothyroidism. Also antibody presence, so presence of the antibody, patient 4.3% of patients each year, if the TBO antibody are present, they will go to the hypothyroidism, to progress to hypothyroidism. 2.6 of patients each year, if negative, they might go to the hypothyroidism. So presence of the TBO, it's very important. It's indicate those patients that might progress to hypothyroidism, or those patients who will not progress to hypothyroidism. What about the complication of subclinical hypothyroidism? It's one of the complications. It's increased the risk of metabolic syndrome and hyperlipidemia. Some of the patients, they have shown that increase the cardiac dysfunction, especially the left ventricular relaxation, diastolic dysfunction. Some patients might develop neuromuscular dysfunction, psychiatric and cognitive dysfunction also in form of depression, bipolar disorder might present in some of the patients with subclinical hypothyroidism. So there is some complication of the subclinical hypothyroidism. What's about the lipid profile, which is present in patients with subclinical hypothyroidism? Usually increased level of total cholesterol, it's increase in the low density lipoprotein, and increase in the level of apolipoprotein B, no changes in triglyceride, and increased level of total cholesterol in subject with high normal TSH level and positive anti-thyroid antibodies. So the total cholesterol will be increased on those patients with subclinical hypothyroidism with normal triglyceride and increase in the apolipoprotein B. This is cardiovascular risk with the presence in this patient with the subclinical hypothyroidism. You see that with the subclinical hypothyroidism, especially in presence of the antibodies, it is the risk of cardiovascular disease increased. So the presence of the antibodies and the presence of the increase in the TSH, it is indicators for the cardiovascular risk and one of the increase the cardiovascular diseases, and especially the myocardial infarction. This is again mortality due to the coronary heart disease. If you look at the control patient and overall survival, and patient with subclinical hypothyroidism, the overall survival and follow-up up to 10 years, it's lower than the control patient. So the survival in patient with subclinical hypothyroidism due to total survival, it is reduced. Also in survival, the mortality due to the coronary heart disease, also it will be less in the control compared to the subclinical hypothyroidism. This is the woman and this is the men survival. It's been shown it's reduced either due to the coronary heart disease or overall survival, mean the other mortality. It is the decrease on those patients with subclinical hypothyroidism compared to the control group without subclinical hypothyroidism. What about the treatment? When we treat the patient with the subclinical hypothyroidism, there is guidelines in those patients with subclinical hypothyroidism, non-pregnant adult with subclinical hypothyroidism. We have to look at the age of the patient and also at the symptoms of the patient and the level of TSH. If the level of TSH more than 10, we have to treat whatever the age, if the patient has symptoms or no symptoms. If the patient has level between 7 to 9.9, we have to consider the age. If the age more than 70 years, we have to look at the presence of the symptoms or not. If the patient less than 70 years and the level between 7 to 9.9 and the age less than 70, we have to treat. But if the patient has the level more than 7 to 9.9, and we have to consider the age of the patient. If it is more than 70, we have to consider the symptoms of the patient. And if there is convincing symptoms of hypothyroidism, we should treat the patient who has the whose age above 70 in the level between 7 to 9.9. If the patient has the level between the upper limit of normal, which is usually 4.2, to 6.9, we have to consider the patient age again. If it is less than 70, usually we don't treat only if the patient has severe symptoms. But if the age less than 70, observe the TSH after 3 months. And usually if the patient has indication for the treatment like hyperlipidemia or the goiters or antibody positive, or the patient has symptoms suggest of thyroid, we have to treat. So the guideline tell us depend on the TSH level. If the TSH more than 10, we should treat. If the TSH above 7, less than between 7 and 9.9, we should consider the age of the patient. Above 70, usually we look at the symptoms. Above less than 70, we should treat. But if the level less than 6.9 above the upper limit of normal and less than 6.9. We should also consider the age. Young age, we look at the symptoms, but elderly patient usually wouldn't treat, just we follow the patient only if there is strong symptoms suggest of hypothyroidism. So we have to consider the age and the level and the symptoms of the patient. So subclinical hypothyroidism with the TSH 7 to 9.9 in younger individual with TSH in this range associated with increased cardiovascular mortality, we should treat those patients. In older patient above 70, we consider treatment if the symptom suggests of hypothyroidism. This is the level between 7 to 9.9. If the level between normal, above the normal until to 6.9, we treat patient less than, if the age of the patient less than 70, who have convincing symptoms suggest of hypothyroidism. Patient with high titer of the antibody also, this is likely to progress rapidly to hypothyroidism, so we should treat. Patient with goiters, we should treat. Presence of goiter or presence of antibody or presence of symptoms, we have to treat in young patients even with mild elevation of TSH. So this is the of a therapeutic trial of low levothyroxine with careful monitoring, especially with positive family history. TSH increase over time. When you follow the patient and you found that the TSH increasing, presence of the antibodies, elevated cholesterol, or the patient has symptoms suggest of hypothyroidism. All these indicators also factors helping us to choose the patient who will benefit from treatment of the subclinical hypothyroidism. What about the dose? The dose in older patients, we have to start with this small dose of thyroxine from 25 to 50. In younger patients, we can give the 1.6 microgram per kg per day, and we follow that TSH after 4 to 6 weeks. So in elderly patients, especially in those patients with cardiovascular disease, we have to start by a small dose, and then we can increase it according to the TSH level. In young patients, expert recommended therapeutic TSH after between this is in the young patient between 0.5, we recommend the TSH till 2.5. Well, the elderly patient, the recommended level of the TSH between 3 to 4. So we have to follow the patient TSH after 4 to 6 weeks to find if the patient is required to increase the dose of thyroxine or not. And we should monitor the dose of thyroxine given to your patient by repeating the TSH, as I mentioned, every 4 to 6 weeks. What about in pregnancy? The patient with subclinical hypothyroidism in pregnancy? TSH might be obtained in pregnant women and women who wish to become pregnant. Even before pregnancy, we have to look at the TSH level. If they have family or personal history of thyroid disease, especially, or patient has goiters, or patient has symptoms suggest of hypothyroidism, or presence of other autoimmune disease like type 1 diabetes, and all women who want to get pregnant or already pregnant, we have to check the thyroid function disease, especially on those patients with family history or patients with goiters or patients with other autoimmune disease. We have to check the thyroid function. What about the treatment? What the guidelines for treatment? Usually in pregnancy, we look at the level above 2.5 as abnormal, especially if there is thyroid antibody present, and there is certain guidelines. We should treat by levothyroxine. It is recommended if the antibody positive woman with TSH greater than pregnancy specific reference range, which is 2.5. Antibody negative woman with TSH greater than 10, we should treat. But if presence of antibodies even above 2.5, we should treat. So in any pregnant woman, if she has TSH more than 2.5, we should look at the antibodies. If the antibody is present, we should recommend the treatment even if the TSH above 2.5. But in case of the absent the antibodies, we should treat only if the TSH above 10. might be considered levothyroxine therapy in patient with the thyroid antibody positive, women with TSH above 2.5 and below the upper limit of pregnancy specific reference range. TBO antibody negative women with TSH greater than pregnancy specific reference range, below 10, even below 10, we might consider, especially if the patient has symptoms, or patient has goiters, or patient has abortion before, or patient has a strong family history of thyroid disease. Even in absence of the antibodies, and even in the level of TSH not reaching above the 10, in the presence of these factors of goiters, or the symptoms of hypothyroidism, or strong family, or patient has fertility before this pregnancy, or a repeated abortion, even the level of TSH less than 10, even in absence of the antibodies, if the TSH above 2.5, we should treat. Levothyroxine therapy is not recommended for those patients who has TSH less than 2.5 and the TBO antibody negative. We shouldn't give the levothyroxine. There is some people with the TBO positive with normal TSH less than 2.5, especially in those patients who has repeated abortion. Some believe they give thyroxine, but there is no strong study to confirm or to prove the benefit of thyroxine on those patients who has TSH less than 4 or less than 2.5 with negative TBO. The other subclinical thyroid disease, what we call it subclinical hyperthyroidism, which is by definition, it is normal T4, normal T3, T4 and T3 and free T3 with low TSH. And this is usually, we call it subclinical hypothyroidism. And this could occur in those patients who has mild Graves' disease or mild hyperthyroidism. Usually it is, if it is the patient have the TSH less than 0.1, it's very clear, but some patients might have mild decrease in the TSH between 0.1 to 0.4, which is the level of the TSH normal between 0.4 above the 0.4, so above less than 0.4, above 0.1, this is mild subclinical hypothyroidism. And usually we look at the patient's symptoms and the level of the TSH when we want to treat. What the causes of subclinical hypothyroidism? It could be due to the exogenous excessive thyroid hormone replacement, thyroid hormone suppression therapy, or endogenous thyroid gland autonomy, or like thyroid adenoma, or multinodular goiters, or as I mentioned, Graves' disease, mild Graves' disease might present in the beginning as subclinical hyperthyroidism. Other causes we have to exclude it of low TSH, delayed recovery of pituitary TSH producing cell during after therapy for hyperthyroidism. In normal pregnancy, especially in the first trimester, you might find low TSH with normal T4. Various non-thyroidal illness, thyroid 6 syndrome also might have low TSH. In the administration of dopamine, glucocorticosteroid, and possibility of dobutamine might lead to low TSH. Endogenous subclinical hyperthyroid TSH less than 0.4 will recommended further evaluation to establish the etiology of the low TSH. We have to assess the uptake of the thyroid to see the uptake. If it is low uptake, that suggests likely to be thyroiditis. If the uptake it is high, this is likely to be hyperthyroidism, either due to the Graves' disease or due to the adenoma. So patient who has TSH lower than 0.4, we have to do the thyroid uptake, radioactive iodine uptake, to assess the uptake to differentiate between thyroiditis and hyperthyroidism. What the concern about subclinical hypothyroidism, or what the problem? It might be causing osteoporosis, especially with long-standing subclinical hypothyroidism. Also might cause arterial fibrillation, cardiac dysfunction, or might progress to overt hyperthyroidism either due to the Graves' disease or adenoma or multinodular goiter. This is the effect on the bone. It reduces the bone density, serum acetylcalcine, also urinary hydroxyproline, and it will be reduced. Also on the heart, because due to the atrial fibrillation, might lead to reduce the cardiac contractility and reduce the left ventricular function. So this is the risk of the, just this slide to show you the, with more lower of TSH, more higher risk for atrial fibrillation, especially in the age above 60. So more lower of the TSH or more severe hyperthyroidism, it is more risk for atrial fibrillation. So the risk of atrial fibrillation, it is related to the level of TSH, more level of TSH, more risk for atrial fibrillation. Prevention and treatment of subclinical hypothyroidism. Oxygenous, we have to look at the dose and we have to reduce the dose. We have to carefully titrate the dose of the thyroxine. But endogenous cause of subclinical hypothyroidism, we have to consider the treatment of hyperthyroidism either by the medical treatment or by the radioactive iodine. So when usually we consider if there is mild subclinical hypothyroidism, the TSH less than 0.4 but above 0.1, between 0.1 to 0.4, it is recommended again routine treatment for all patients who has mild decrease. We are against to routinely to treat only on the patient who has symptoms or patient who has goiters or patient who has clinically suggest of Graves' disease or toxic adenoma, we treat. But if the patient has mild symptoms and mild decrease in the level of TSH, we not usually we treat patient with the subclinical. However, because of the possible association with increased cardiovascular, especially in elderly patient with high risk for atrial fibrillation, we might consider treatment for the elderly patient to avoid the risk of the atrial fibrillation. So mild decrease in the TSH in case of subclinical hypothyroidism would treat if there is risk for atrial fibrillation, especially in the elderly patient. But if the level less than 0.1, we have to do the radioactive iodine to assess the uptake. If the patient has increased the uptake, we should treat by the antithyroid or by radioactive iodine. So the more lower, less than 0.1, the subclinical hyperthyroidism TSH more than 0.1, we should treat. If the patient has some severe lowering of TSH, we should treat. And the treatment, the ideal treatment for patient with hyperthyroidism, it is the radioactive iodine. Finally, what the consensus from the subclinical hypothyroidism or hyperthyroidism treatment in subclinical hypothyroidism, it's reasonable for patients with TSH above 10. It is reasonable for anyone above 10, but treatment should be considered with TSH above 4.5, less than 10, with key determinant being the clinical judgment according to the age of the patient and symptoms of the patient and the presence of goiters, presence of hyperlipidemia. We should consider the treatment if the patient has symptoms, has strong family history of thyroid disease, goiters, and especially in young patient. In the elderly patient, less than 7, we might need just to follow the patient, especially if there is no convincing symptoms of hypothyroidism. Where the subclinical hypothyroidism, it depends on the level of TSH. TSH less than 0.1, we consider doing the radioactive iodine uptake, and we should treat if there is increase in the uptake. But if there is patient has between 0.1 to 0.4, we should consider treatment only if there is risk of atrial fibrillation, especially in the elderly patient. Otherwise, we should follow the patient and repeat the thyroid function test every 2 to 3 months. This is about the subclinical hypothyroidism, and wish for all of you the best. And I end my lectures There is a strong relation between thyroid disease and heart. When the thyroid speak, the heart listen, because the thyroid disease is one of the risk factor for either the arrhythmias or dysfunction, cardiac dysfunction. So we have to consider the treatment of thyroid, especially if there is subclinical hypothyroidism or hyperthyroidism or hypothyroidism because of the risk on the heart or on osteoporosis. Thanks for all of you, and thanks for the organizer committee. I wish the successful for the Arab Thyroid Society, and thanks for everyone.
Thank you, Prof. Abdulrahman Sheikh, for this excellent presentation. Now I would like to ask all the speakers to come to the screen, and Dr. Prof. Abbas will lead the discussion. Prof. Abbas, you are mute.
You are mute, Dr. Abbas.
We have a patient who is post-surgery, have a hypothyroidism, and TSH is around 30 on 400 microgram L-thyroxine with a history of malabsorption to celiac disease and laparotomy from previous perforated DU. I will ask Dr. Saud if you hear me, if you hear the questions.
Sorry, what was the question, Dr. Abbas? I didn't.
The question, post-surgery, hypothyroidism, the patient is also having celiac disease and having DU surgery for perforated DU. He is on thyroxine 300 microgram per day. Still the TSH or 400, still the TSH is not in the target, is around 30.
Okay, so this is post-thyroid surgery, isn't it?
Dr. Saud, you get the question?
Yes. So is it post-thyroid surgery, this patient?
Yes, post-surgery.
Okay.
Post-surgery, he is known to have celiac disease and perforated DU surgery.
Okay.
He's on very high dose thyroxine.
Okay. In this situation, I would, before looking into thyroid resistance, which might be in few cases, I wanted to make sure that he has got the full absorption of the dose. Maybe since he's having a perforated ulcer plus celiac disease, he might be difficult to know the absorption rate. So he might have a problem in the absorption, or the other thing, he might have some people we have seen, they have got resistance to the thyroxine, if we make sure that the patient is taking it appropriate.
Okay.
Yeah.
Second question, we have a primary hypo. Do you need routinely to measure the free T4 or total T4 with the TSH, or only you follow the patient with TSH?
Thank you very much. The standard is to measure only TSH. So with those primary hypothyroidism, I would go with only measuring TSH, except in few cases where you would find discrepancy between the clinical status of the patient and the result of the TSH. So maybe in that situation, I would do both. But the routine, always we follow them only with TSH, except in this situation or the other situations where I would look for patients who are post-thyroid cancer thyroidectomy.
Yes. The other questions, we have seen a patient with a TSH of around 8, normal free T4 and total T3, referred by anesthesiologist. They need to give anesthesia and they normalize TSH. What to tell the anesthesiologist in this state?
Okay, in these situations,
nobody give general anesthesia with a TSH of 8.
Okay, and in these situations, usually for patients who are going for general anesthesia, you don't need really to have a very normal TSH. If TSH is below 10, I'll be happy to proceed with the general surgery. In those, I would say, emergency situations, even if the TSH is more than 10, I would elect to go for the emergency surgery. Why is that? The only thing I would take in precautions that those patients seen, usually they would have what we call it difficulty in extubating them from post surgery because of accumulation of fluid in the lung. Apart from this, usually they don't have much problem if it is emergency surgery.
Yes, I will ask also Professor Abdurrahman, he is with us.
Yes.
This is subclinical hypo, and the anesthesiologist need to normalize TSH before elective surgery. Do you believe in that, or we disagree with the anesthesiologist?
Actually, as mentioned by Dr. Saud, I disagree with the anesthesia usually, and even forcing us to normalize the T4 before any surgery. In case of, if it is above 20, only we go for emergency situation. We can tell and they have to sign against the high risk consent for the patient if it is emergency. But if it is not emergency above 20, we will not do it, we will wait. For as answering your question, if it is just subclinical, you didn't need, just you give thyroxine, but you didn't need to normalize it before surgery. I agree, especially if it is less than 10.
السؤال للدكتور علي once Down syndrome Mongol present with goiter and biochemical hyperthyroidism with very high level of TBO and low titer of TRAB antibodies. How you differentiate in this case between Graves and Hashimoto toxicosis, given that both are more common in this disease?
Yeah, this is a good question because actually both are common. What is important is actually the presentation. If the patient is hyperthyroid and the receptor antibody are positive, obviously this is in keeping with what we call autoimmune thyroid disease. Whether it is, and it needs to be treated, whether it is, we call it the Graves' disease or thyroiditis, is irrelevant because we have cases where we call it thyroid Hypothyroidism, where they have an ultrasound feature of thyroiditis, and at the same time they are overly active. So in that case is the clinical presentation that dictate the treatment, and usually I follow those patients. Most of those patients will have positive thyroid antibodies along with positive TSH receptor antibodies. So my answer is treat.
Thank you. Dr. Tariq, if you continue with the questions, for whom this question, the oral dose of prednisone and the duration of treatment for Graves orbitopathy. Dr. Tariq, please. Would you ask anybody?
Yes, please. Dr. Ali.
Okay. Well, I have to say that in case of Graves orbitopathy, obviously you have to treat the hyperthyroid case. This is really important. You have to advise the patient of stopping smoking if they do smoke, because smoking has really a relevant effect on the orbitopathy. And you have to judge the degree of severity of the orbitopathy. Okay, is mild to moderate. I mean, mild cases, some suggest use of selenium, some cases. But if the decision is made to use a steroid in moderate cases, there are two protocols. One, the most commonly used, is the IV methylprednisolone, and usually we start initial dose 0.5 gram IV weekly, and then we make it 0.25 for a total of 6 weeks, not to exceed 8 milligram total dose.
80 gram, you mean 80 gram?
80 grams, sorry. And in that case, if you decide to go for oral medication, usually we start with high dose prednisone, which is 100 milligram, that we taper progressively 10 milligram per week according to the response of the patient.
Dr. Tariq, if you allow me to ask him, do you believe in oral prednisolone or you just injectable? Dr. Ali, تسمعني? You hear me?
If you ask me or Dr. Tariq, asking Dr. Tariq.
لا, to Dr. Ali.
the best effect is usually with IV prednisolone, okay? And the other use for cortisone is in acute vision loss. Not methylprednisolone is used, is dexamethasone is used as a large dose 4 milligram IV, just buying time before orbital decompression is used. But IV use is better than oral use.
دكتور طارق انه وصلنا للسؤال اللي نوتروبينيا تشوفوا.
Thank you Prof Ali. Question for Dr. Abdurrahman. Is there any complication if we leave the patient with hypo or hyperthyroidism untreated?
As I mentioned in the lecture about the progression of the subclinical hypothyroidism, only almost 4% of the antibody positive, they will progress to hypothyroidism. If there is patient, elderly patient might have risk of treating by thyroxine more than not giving the treatment. So you have to wait the patient and you have to look at the age of the patient, the level of TSH before starting. But there is no problem if you wait and follow the patient. Some of them, they might be normalized. Only 4% of those patients may be progressed to hypothyroidism. So there is no risk, especially if the patient, elderly patient, no symptoms, no antibody, no goiters, and no hyperlipidemia. So there is no risk from treatment, no risk from waiting.
Thank you, Prof. Abdurrahman. And how to follow subclinical hyperthyroid on treatment?
Subclinical hypothyroid, if there is mild decrease in TSH and young patient, we just follow. But if there is less than 0.1 decrease in the TSH, we have to do the radioactive uptake. We have to assess the uptake to differentiate between thyroiditis, as mentioned by our colleague, and hyperthyroidism. If it is hyperthyroidism, I usually go for treatment by radioactive iodine. There is just a comment about I have a patient, middle-aged patient, which is I followed for almost 5 years now. And for 5 years, she having, sometimes I found that there is low TSH, sometimes high TSH, so she's fluctuating from hypo and hyper. And even the thyroid uptake, when she was hyper, it was normal uptake. So likely to be Hashimotoxicosis and fluctuating between hypo and hyper. But taking all this time, for now, for 5 years, the patient coming every time there is changing in the TSH, either increased TSH or lower TSH, and shall we go and treat her by radioactive iodine or surgery, removal of the gland, then we'll give replacement, or just to wait and we'll look at the thyroid function test, repeating it till she become hypo, because it's long duration now, 5 years, she's fluctuating between hypo and hyper. And shall we treat her as she is having hyper and remove the thyroid by radioactive iodine or by surgery, and then we'll replace thyroxine, or just we'll wait till she become hypo by herself? I don't know if any one of you have any opinion for this.
Can I reply to this question?
Yes.
I think, as you mentioned, really looking at the patient clinically is the most important point. Let me make the point really about those suppressed TSH, and especially for family physician, because this is an important point to make. Most of those patients that present to your clinic with suppressed TSH, especially when, as you mentioned, that they are above 0.01, if you repeat the test within 6-month period, 3 to 6 month period, there is a very high likely that the TSH would normalize. And then repeating the test will be back to normal, and you will avoid really all the investigation that need to be done. Even in studies that patient looked for 5 years period, 30% of those patients will end up having normalized TSH. If the patient has no clinical impact, no clinical symptomatology, and the patient is asymptomatic, really, I think, and no risk, and that's where really I make the difference. TSH, suppressed TSH, you should classify your patient low risk, high risk. Low risk below the age of 65, high risk above the age of 65. And those below the 65, you can wait, and there's no harm by waiting if the patient is asymptomatic. Above 65, if they have underlying cardiovascular disease or other risk factors, then the option of treatment is more imminent, and you have to make a choice. So if your patient is asymptomatic, I'll follow up. The thyroid might declare itself one way or another.
Thank you, Dr. Ali.
And even, Dr. Tariq, we face this also in the pregnancy. In the first trimester, this is normal. Some patients, they might have low TSH. So this, we receive many referral from our colleague from the primary healthcare as hyperthyroidism, and some of them, they even given the treatment by the primary healthcare, which could be normal low TSH in the first trimester of pregnancy. So I agree with Dr. Ali, we have to wait till most of them might be normalized.
Thank you, Prof. Abdurrahman. A question for Dr. Saud Sifri. For patient with infertility, at which level you start treatment? What level of the TSH you start treatment? And what is the target for TSH in patient for going for the IVF?
Okay, thank you very much. This is an important question. Now, for patients who has got subfertility or infertility, always we should screen for TSH. And then if I find it less than 4 as a cut-off point, and that patient is having subfertility, I would treat. And the aim is to reach below 3, the upper limit of for him. If patient is going for IVF, in that situation, 2.5 as an upper limit would be my target for TSH.
Thank you, Dr. Yusuf, Dr. Saud. Last question before I go back.
The question is about neutropenia. That is, yes.
Yeah, if patient developed a granulocytosis after using antithyroid medications, after stopping the drug, when can we resume it? Or we have to change the line of treatment to surgery or reductide for Dr. Ali?
Yeah, thank you very much. As a clear answer, I mean, if they develop agranulocytosis, please stay away from those drugs, because really the risk of really is very high, and you should never really try them again. And you should adopt really another better therapy in this case.
Thank you, Dr. Ali. Prof. Abbas?
Yes, what is the effect of hyperthyroidism on renal function, Dr. Ali? Again, to Dr. Ali, are you aware of renal effect of hyperthyroidism?
Well, there are some cases, actually, there are animal studies really that looked into this. Because the hyperthyroidism, what it does, it increases renal blood flow, and your glomerular filtration is also increased. So in patients who have underlying mild renal disease, that might be masked if the patient has hyperthyroidism. And when you start treatment, the patient will show signs of really mild renal failure, which was pre-existent, but was masked by the hyperthyroid stage. So this is something to keep in mind. Now, if the patient has had long-standing hyperthyroidism and treated, because really the effect on the heart and the renal perfusion, there might be some in animal study that found that really sometimes there are some glomerular damage that occur and that might impact the renal function. But this is really in extreme cases. Usually it really has no impact. Obviously, if you have someone with renal failure, you have to watch the amount of drugs you're giving because of the clearance issue. But otherwise, really, the changes are very minimal. But keep in mind, it might mask really some degree of renal impairment.
Dr. Ali, the same question for you. Do you start methimazole full dose, or you gradually escalate the dose?
Well,
for hyperthyroidism.
Yes. Again, the classical teaching is you have to adjust the status of the hyperthyroidism. You have to divide them between mild cases, moderate cases, and high cases. And the dose is progressive according to the initial case that you're having. My philosophy, this is really what you see in the textbooks, but my philosophy is that if the patient is hyperthyroid, is to treat them aggressively to induce as fast as possible the hypothyroid stage, because that would
Which mean the dose in adult. What is the dose in adult, you mean? In methimazole, carbimazole?
Yeah, in mild cases, you can start with 5 to 10 milligram, moderate cases between 10 and 20 milligram, And then severe cases, I can reach up to 60 milligram. So this is really the way I look at
methimazole, you mean? Methimazole, not carbimazole. Yes.
Metimazole
The other...
is 10 milligram carbimazole is equal to 6 milligram metimazole. So they are mostly interchangeable. So it doesn't make a difference.
The other question, Professor Abdulrahman, لا تسمعني. يقول إنه you have unilateral apoptosis and there is a TRAB negatives and subclinical hyperthyroidism. You will treat or not?
I will treat.
As a thyroid eye disease.
I will treat, because this, yeah, I will treat, especially if the TSH lower than 0.1, I will treat. Because he has a problem now, he has exophthalmos, he has the autoimmune, I will treat. I don't know about the other colleague, but if they have subclinical hyperthyroidism with exophthalmos, I will treat, especially I want to reduce the autoimmune, because exophthalmos, as you know, it's related to the autoimmune reaction.
نعم. دكتور عبد الرحمن أيضا لك نفس السؤال، هو كان يسأل على usual TSH in pregnancy. I think the question by you.
Answered by Dr. Saud.
What is the normal TSH?
Usually, as mentioned by Dr. Saud, the cut point is 4, but usually we lower the TSH in pregnancy to be less than 2.5.
نعم. سؤال للبروفيسور عبد الرحمن. Many thanks for this wonderful lectures. I am asking about the upper limit cutoff of TSHU depend above which you are diagnosed subclinical hypo, as there are
subclinical hypo if it is
age and gender above, specific value.
Yeah, if it is above 4.2 with normal T4 and T3, we call it subclinical hypothyroidism. If there is increased TSH above the cut normal, which is 4.2, we call the subclinical hypothyroidism. Oh, there is something interesting. I want just to mention it while we are now with the new drugs of diabetes, semaglutide, oral semaglutide, it will enhance the absorption of thyroxine. So just we have to be careful when you start semaglutide orally. You have to avoid the time of thyroxine all in the morning before meal. So you have to avoid not to give it together with thyroxine. And even you have to observe the thyroid function test after starting the semaglutide, because the semaglutide already enhances the absorption of thyroxine. Just I want to mention it.
أعتقد he's asking also, do you have normal Saudi normal values for your platform you are using or the electrochemolucent TSH for the country? Because you know we have to have every country his own normal TSH. There are variabilities sometimes according to the platform. You are talking about kit.
Well, I think we should have for our Arab area. Now with this Arab Thyroid Society, we need a lot of things, guidelines, and we need normal level of our area. So with this society, I think it is very important things to be done. The guidelines for treatment of thyroid, hyperthyroidism, and also the normal level of TSH. I don't know if Saudi is aware about any normal level for Saudi population.
No, I'm not aware, and I think really we are lacking these data in Arab world. So I think, but what we are using is really the international reference, but having a local for Arab countries, I think this would be a good thing really of working on it. Yes.
May I add that really we have done a study actually on our nationals in Abu Dhabi, and then we have set the normality for TSH in the first trimester, second and third trimester. And then our upper limit actually was 3.5, and which goes with what has been roughly done in other Asian studies. Some, as you know, that Asian study seems to have a higher TSH value compared to other. But I know that there is an initiative from the person heading the National Reference Lab to make it within the Gulf region, and then she was getting Roche support for this. But again, she was told and delayed to achieve this project. But it's very important to have trimester and population TSH ratio.
Yes. There's last two questions to Dr. Saud, if you hear me. How you manage a TBO positive normal thyroid function patient? And the second questions, Dr. Saud Aylan, do you need goiter to diagnose Hashimoto or not necessary?
Thank you. I'll start with Prof. Abbas. I'll start with the last one. No, we don't need to have a definitive diagnosis for Hashimoto thyroiditis. So you need really to go for autoantibodies because as
he's asking, do you need goiter? Do you need goiter? I mean, do you need goiter to diagnose Hashimoto or not necessarily?
No. We might, it might be of, let's say, hard consistency, heterogeneous, and it might be a small one. So it's not a goiter. Hashimoto thyroiditis, autoimmune disease, even without enlargement in the size. The only thing is maybe presence of bodies, autoantibodies, but this is not necessary for diagnosis because the definitive diagnosis goes with biopsy, which is not necessary, not indicated to be done because in most of cases, the management is the same. Thank you.
Yes, second question, how you treat TBO positive patients with normal thyroid function? How you manage?
Normal thyroid function, for me, positive TBO antibodies does not indicate or necessitate treatment. It only tell me that this patient might have more progression towards overt hypothyroidism. So I would have, for example, annual examination or annual testing for him. That's it, but no treatment.
Thank you. Dr. Tariq, now it is time for you, the microphone with you to have the closing remarks. And if I missed any of the questions of the audience.
Thank you, Prof. Abbas. I would like to thank all the speakers and our participants for excellent presentation and for the excellent, valuable discussion. And I will remind all our speakers, our attendants that we will have our second session or second webinar on 25th of October after 2 weeks. Please join us and thank you very much for all the participants and thank we'll thank Dr. Nasser Al-Jahani and the organizing committee and extended our thanks to the Merck company for their sponsorship. Be safe and see you inshallah soon in the second webinar. Thank you. Good evening.
شكرا
Thank you very much. Assalamu alaikum.
Thank you.
Thank you very much.
Assalamu alaikum.
Assalamu alaikum.
Assalamu alaikum. Assalamu alaikum.